everyone. Thanks for logging in. I think just a couple more people are coming through the waiting room. We'll get started in about a minute here. All right. Good evening, everyone. Thank you so much for signing in tonight to learn more about trauma-informed care in emergency medicine. My name is Taylor Brown, and I'm a PGY2 resident at Beth Israel's program. I'm a member of the RAMS board and a passionate advocate for trauma-informed care. We've organized tonight's session in hopes of increasing awareness about TIC in our field and also to highlight some of the extraordinary work that is already underway in our specialty. Tonight's session will begin with a brief didactic that'll be presented by Dr. Henry Ashworth. They'll be followed by a moderated panel, and then we'll open it up to audience Q&A. The didactic portion will be interactive, so we invite you to utilize the chat throughout, so this can be really an ongoing conversation. And we'd just like to add, we begin all of these talks with a content advisory. Although we won't be discussing traumatic events in detail, reflecting on trauma-informed care can be distressing. So please practice self-care however you need. If you just need to put the earbuds in and tune in and not participate, that's fine with us. And with that, I will turn it over to Dr. Ashworth.
So as Taylor said, we'd like to make this didactic short so we can get onto a wonderful panel, but also make it as interactive as possible. So please utilize the chat. We'll be asking some questions. We would love to hear your own thoughts as we go through. So for this didactic, we have three main goals. These objectives are really to just define trauma, the window of tolerance, and the 6 principles of trauma-informed care. And then we'll go on to discuss the efficacy of trauma-informed care and the current research that's out there that shows how trauma-informed care improves outcomes for our patients. And then we'll talk about some specific approaches to trauma-informed care, which will also dovetail into our panel. So when we think about trauma, we like to define it by the 3 E's. And this is in the same definition of trauma. We think of a code activation of like a trauma level 1 coming in or a level 2. We think of trauma as being events that a person experiences that then lead to individual experiences, events that lead to individual experiences that affect someone either emotionally or physically. And these have a lasting effect on an individual on both the social, mental, emotional, and spiritual level. And I think we can all kind of imagine the different forms of trauma that our patients experience and how that leads to the certain effect they have. And I often think about how the environment in the emergency department can be a place where patients experience a lot of trauma and how getting back into that environment in the emergency department leads to a re-traumatization. And I'd love for other people to put in the chat about kind of different forms of trauma that we don't think of as classic trauma that kind of follow this definition. Next slide, Taylor. And whenever we talk about trauma and kind of this broader definition, I think it's always important to think about what is the overall breadth of trauma that is experienced in our population. And one good example of this are adverse childhood experiences, or ACEs. And there was quite a seminal study done in the 1990s that tried to understand, what is the overall level of trauma that children experience in our population. And they defined these ACEs quite across a broad range. And this slide kind of has a few different definitions of what are adverse childhood experiences. And they found that trauma is quite broad and experienced by a very, large part of our population. About 50%, over half the population, has experienced one of these adverse childhood experiences, and that they also cluster. And if you experience one or more, then you're more likely to have other traumatic experiences in adulthood. And that overall, these ACEs and experiences in adulthood lead to really important and harmful long-term health outcomes. And this is even multiplied for patients in our emergency department. And the patients that we see often have higher levels of ACEs, which has been shown throughout the research. And I also think it's important to rethink about trauma and caring for our patients, also the trauma that we experience. And I'm sure most people on this call are familiar with the 2018 ASAP study that looked at about what is the level of trauma that we're experiencing as providers. And about 50% of EM physicians have reported, at least in 1 year of practice, that they experienced some level of physical assault from caring for patients. And this is also experienced by our nursing colleagues and has led to a large percentage of us as providers experiencing PTSD or secondary traumatic stress. And I think it's always important to think about how trauma-informed care can also help us provide care as providers. So now getting into how we actually think about applying trauma-informed care. I love this framework of the window of tolerance. So I think it helps me understand where patients are at and how I can adapt my trauma-informed care interventions to help get them into that window of tolerance where they can engage in their care. And I think it's very easy for us to think about the hyperaroused patient, the patient that is having a huge sympathetic response, they're in a fight or flight state, and how we need to help de-escalate them. But I think it's also really important to think about that hyperaroused state and how patients can either seem numb or disconnected, have a flat affect. And we usually don't worry about these patients because they're not usually causing issues in the emergency department, but they also are in a state where they're not really able to engage in their care. And this can prevent them from really us helping like form that therapeutic alliance to get them to a better place to engage in their care. And so I think about whenever I approach a patient, what's going on is where are they in this window of tolerance and how we can help direct them with our trauma-informed interventions to get them back in a place so they can engage in the care. So now onto the 6 principles. So these are the 6 principles that SAMHSA uses to define trauma-informed care, and they're safety, trust and transparency, peer support, collaboration, mutuality, empowerment, voice and choice, and culture, gender, historical considerations. And while each of these are separate, they definitely overlap, and often one trauma-informed care intervention can use a few of these in one. So I don't always think of them as separate, but they often blend together and are collaborative. And then the next slide, I think this would be a great time for people to chime in the chat, and we can talk about how other people have used or view trauma-informed care interventions that kind of work into these 6. And we're also happy to provide examples as well if people are a little shy in the chat. So for the first one, for safety, I like to think of safety as being not just a physical space, but also the emotional and the psychological space as well. If anyone could put in the chat kind of a trauma-informed care intervention they think about of how to make a safe space, make a space safer for a patient. Not seeing anything in the chat right now. Oop, there we go. Introduce yourself and the learner's on shift. Definitely agree with that, Taylor. Believe them. Yep, I agree as well. It's really important for them to feel like they are in the place that they're in is a place where they can entrust. And I think that also builds into trust and transparency, where they're safe and they can actually divulge the information that's important for them to receiving proper care. Yes, acknowledge and validate concerns. Ooh, moving security guards. I think that's extremely important. At least here, I'm a resident Highland. We have quite a number of police and security guards as well in our emergency department. And I often always think about handcuffs as well, and how we can, when it's safe and possible, to remove handcuffs to do the physical exam to kind of help, inform that alliance with the patient. Also, I know we'll do a lot of evaluations in hallways, but then taking the extra time either to move to a private room or then get those extra curtains to help provide that privacy. All wonderful examples. Great, and I think now moving on to the next one of trust and transparency, I think the one that that Judy Linden just thrown is a great one for that as well, besides just safety, explaining the process to the patient. And I think that really helps build complete transparency of what they can expect. And that helps them then build and create trust with the providers, and not just you, but the rest of the team. What are some other good examples of trust and transparency that people utilize? I think one, especially getting to the colleague level, is always acknowledging there's going to be other providers and that there's going to be a whole team, whether it's going to be techs, nurses, residents, attendings, but kind of creating that transparency. There's going to be a lot of different people so that they understand there's going to be a lot of people coming by the bed. Hani put in acknowledging errors. That's really important and can be very challenging as well, especially if they're medical errors and have repercussions. Ooh, Michael Cleary, I think that's a wonderful example, naming why we're asking questions. I think that also goes into physical exam, explaining why we're doing physical exam maneuvers. So I think a lot of times for us, we have that quick explanation. We want to move quickly into it, but especially more sensitive physical exam maneuvers, it's important to really explain that so the patient understands why we're going about what we're doing. Ralph, I love your point as well, asking directly if they have concerns. And that also kind of bleeds into empowerment, voice, and choice, but also is really important for trust and transparency of how we can really make sure that their voice is heard and that we're being very transparent what we're trying to do and that their goals are being met as well. Natalie, I completely agree. And I think that's something that is sometimes often overlooked. And I still make the mistake of not always asking for preferred pronouns in assessing a patient, especially if they're older. I definitely have a bias where I forget to do that. I think that's a wonderful example and is a great way to form that trust very early on in patient encounter. So next, for peer support, I think with this one, I'd love to hear people's thoughts as well too of how to help engender peer support for when it comes to the institutional level and also other providers. So an example that I think of really important with peer support is, making sure and acknowledging that other colleagues are going to come by, and that kind of providing that warm handoff to them by saying, this is their provider, they're excellent, and then expecting that they'll come by and see them, so that the whole team becomes a part of this patient's experience. Taylor, I love that idea, especially in COVID, of having another person be there over FaceTime. That can definitely be important, especially also if there's a language barrier. Even if we're using a translator, it's just nice to have someone else who speaks their own language and is a family member to chime in and be a part of their care. Judy, I think it's a wonderful example as well. Making sure, especially, we think of trauma-informed care as a universal precaution for all patients, but especially for patients who are survivors or have recently experienced an assault, making sure that we're including their local rape area crisis center, and then also the DV advocates in the ED. And Sally, that's a great point. Thanks for mentioning my terminology. Definitely just asking for pronouns overall is the right wording to use. So we have about another minute. So I'd like to just move on to the final slide. I think those are all good examples. And thank you everyone for chiming in. On this final slide, I just really wanted to go over all the research out there. And at the end of this presentation, we have a link for a whole bunch of resources of trauma-informed care, and that covers all the literature out there. We did a trauma-informed systematic review of trauma-informed care in the ED about a year ago, and all the research out there right now definitely has some positive impacts of what trauma-informed care is doing, even though we have a lot more research to do and a lot more to, I think, show and demonstrate of how impactful trauma-informed care can be. But from the research that is out there, it's been shown to reduce the number of patients that are put in restraints and the time they're in restraints. And those are physical restraints, but also connects to chemical restraints as well. It improves the quality of service for survivors of sexual assault. It's increased the safety and the efficiency of reporting for survivors of human trafficking. It's also improved how well we screen youth, but I would imagine it goes for adults too, on assessing overall suicide risk and making safe planning once they're discharged from the ED. And then also there's definitely been some great reports on how it can help an entire care team heal, including providers across all levels. And a good case report from that was from the Boston Marathon out of Brigham and Women's. So thank you all for participating. I hope this was a useful kind of mini intro and helps kind of set the stage for our wonderful panel that's up next.
I have the pleasure of introducing tonight's panelists. So I've chosen to go in alphabetical order. So we'll start with Dr. Michael Cleary. He's an assistant professor at Grady Hospital for Emory Health. His clinical interests involve interventions and treatment and the prevention of violent injury, as well as trauma-informed care. He recently joined the City of Atlanta Mayor's Office of Violence Reduction as the inaugural deputy director. We're also joined by Dr. Nathan Irvin, who's an assistant professor at Johns Hopkins. He's an expert in social emergency medicine. He's the director of a fourth-year social emergency medicine elective. He also serves as the co-director of the Health Humanities at Hopkins EM initiative, which helps to offer social justice and humanities-based education within its institution, community, and national audiences. We have Dr. Judy Linden, who is a professor and vice chair in the Department of Emergency Medicine at Boston University. She is a sexual assault examiner for the state of Massachusetts. She's also helped to create and implement some collaborative educational sessions to instruct residents in the acute care setting for patients presenting after sexual assault using a trauma-informed care framework. She's a member of AWEM and the chair of the ACEP's forensics section. Finally, we have Dr. Hani Stoklosa. She's a co-founder and CMO of Heal Trafficking. She's an emergency physician at Brigham and Women's Hospital with teaching appointments at Harvard Medical School and the Harvard Humanitarian Initiative. Dr. Stoklosa is an internationally recognized expert, advocate, and researcher for the well-being of trafficking survivors in the US and internationally. So with that, I will stop sharing my screen so we can see our panelists. And I'd like to kick off the moderated session with a question that we'll ask Dr. Linden first, but the panelists feel free to all chime in. I think Henry gave us an excellent summary and overview of what trauma-informed care is. But how do you think about the difference between providing trauma-informed care and providing, good empathic care that we would traditionally be taught to provide?
That's a great question. Thank you for asking that. So both of these are tools that a provider can use to improve patient outcomes and experience. Empathetic care involves active listening, relating to, at least on some level, and validating a patient's experience or concerns. Of course, trauma-informed care requires empathy, but more than that, what it does is offer us a framework for creating a safe environment for our patients who have a history of trauma, which we know from the prior introduction is a large number. Trauma-informed care helps us recognize that many of our patients have had traumatic experiences that affect their current interactions with the health system. We often do not know which of our patients have a history of trauma, so it's best probably to assume that all do. In the introduction, we talked a little bit about the 6 guiding principles of trauma-informed care. Incorporating this framework gives providers and systems concrete interactions that can help us create a safe environment, help us to engage and collaborate with the patient to improve care and outcomes. And so just on a personal level, I find that using trauma-informed care framework actually helps make it easier for me to find empathy toward my patients, especially those that aren't behaving in a way that I'm able to understand. It helps me shift the question from what's wrong with you to what has happened to you that is causing you to respond or act in this way. And this really helps me check my assumptions and judgments.
I think you bring up such a great point too of trauma-informed care as a universal precaution and something that we can use with all of our patients. Dr. Saklosa, I'd like to ask you a question kind of in thinking about trauma as a universal precaution and something that we can use departmentally and as a whole emergency medicine institution. I know that your group with the Robert Wood Johnson Foundation has done some work on trauma-informed care overall in the department. So how did you think about that paradigm shift within kind of taking it a step larger within your institution?
Thanks so much, Taylor. And it's good to see a lot of familiar faces out there. Greetings from sunny Boston. So yeah, a couple of thoughts here. I think I'll start with my own kind of personal journey around this. As was alluded to earlier, when I had finished training in emergency medicine, I really only had the concept of trauma as physical trauma. And it was actually through my work with trafficking survivors who I work with as colleagues, where I really had my eyes open to what trauma-informed care was and how vital it is to our practice in emergency medicine. And it's like a no-brainer in many ways, but in some ways we're also the last frontier, which is like kind of startling, right? Like I learned this from my survivor colleagues and social work colleagues, et cetera. And I found it, just as Judy was saying, to be incredibly helpful in providing empathetic care, high quality care, efficient care. And so it's really been transformative. And I think of it as a practice. Like this is not every shift I'm trying things on for size and with different patients, trying to be really patient-centered and customizing the principles to that encounter, recognizing that so much is like out of our control, right? Like it's utter chaos. So I just wanted to kind of lead with that. But as we think about shifting culture, which is a lot bigger than and is the most important groundwater state, right? We can raise all the awareness we want, but as we shift culture, I encourage us all to think strategically about what that means in our departments. Each of our departments has their own culture. And so what works in my department may not translate to another department. And so look at what's been successful for other initiatives. I think for us, it was a simple place to start, like really break down what those ingredients were, talk to the people that were the change makers for those other initiatives and get a sense of how they were successful. So that's a broad principle. And then there's 3 things that I think are really core as you look at just generally like what helps create change in emergency department. One is leadership buy-in, and knowing what what really resonates with your leaders is important. So leadership buy-in, aligning with existing strategic priorities, because the house is burning, everything's like on fire. So we really need to make sure that we're integrating into current initiatives. And then third, really building your team. This is not something you can do as an island. And so as it relates to leadership buy-in, again, finding things that are resonant, which might be length of stay arguments. It might be like use the bibliography that we're sharing with you to really have that data argument. This may be something that really resonates on a wellness and burnout level, or an equity level, or both. And so I know in my own department, those are really important priorities right now. And I personally see this as a wellness piece for me as a clinician. I feel like I'm better able to connect with my patients, and I'm less burned out whenever I'm practicing trauma-informed care. And that's absolutely an equity issue. And then collect data along with along with that team. So, you at the end of the day, start small. I always encourage folks, no matter what they're doing, to pick one thing that that your team kind of agrees on is like, this is the starting place. So that might be restraints. That might be, Henry mentioned handcuffs. That might be pelvic exams. That might be pelvic ultrasounds and how we explain them to our patients. But start with something that's that's doable. And so you can collect data and make the case for further work, and think of this as a constant quality improvement initiative, just as we do so much of our other work. So those are some thoughts on that, Taylor.
So many good things to pick up on, but I promised each panelist I would give them a question to start. The next question is for Dr. Irvin. Multiple of you all have worked on educational interventions, and I know Henry highlighted some as well in his didactic portion. I'd like to hear how you think about teaching trauma-informed care, and then how do you think about including our learners in these trauma-informed initiatives?
Yeah, I think it's a really important foundational principle that we should uphold in medicine and medical education. One of my hats is that of a assistant dean for DI in School of Medicine, and so I'm tasked with trying to figure out how to support all these different learners with all these different experiences, with all these different traumas that they've experienced, navigate a system that oftentimes re-traumatizes them. And so I think one of the beauties of this sort of framework is it's one that's proactive about really thinking about how do we resist re-traumatization, how we develop policies and systems and put those in place so that we don't have to think about this stuff so much, because we're already sort of doing it, and it's sort of built into the framework of what it is that we do. And so I think it's a really powerful framework. I think from my perspective, I think exposing our learners to patients who've experienced trauma has been something that really sort of opens their eyes to it, but then sort of turning that lens back on themselves and having them sort of explore their own experiences of trauma, and recognizing that not only does universal consciousness apply to the care that we deliver, it also applies to our space as educators, and our space as individuals who work with learners who also are experiencing trauma, and particularly in the environment that we work at in an emergency department, where things are chaotic, where people are oftentimes going to be triggered by lots of different things that happen. That sense of safety, that sense of sort of being in that window of tolerance can easily go out of whack. And so I think it's really important to set the stage every shift, every day with your learners, know who they are, acknowledge them, build rapport, let them know that you have their back, that they're not alone, that you're not going to lead them out on a limb. I think those things that really kind of empower that sense of psychological safety is really, really key for helping to support learners. I think empowering voice and empowering them to be able to express when they're not doing well, and giving them time and space to be able to do what they have to do to get themselves together, I think is important. And I think another part of it is like really sort of focusing on those relationships with your learners. I think once you start to know who your learners are, you start to understand or see when they are deviating from their norms. So you can start to recognize some of those symptoms in your learners, and start to sort of be proactive about reaching out to them and figuring out how to better sort of support them. And so I think there's a lot of things that we do with learners that really parallels the work that has to be done with patients, and really sort of creates a great sort of synergy for thinking about how do we address trauma as a system, and all those involved, whether it's the patient, whether it's the faculty member, whether it's a student or tech or anybody else that sort of encounters that space.
You brought up such an awesome visual that I want to highlight for everyone again when you mentioned the window of tolerance, which Henry showed in his didactic, and thinking about how our learners can ride that roller coaster too, and they're not going to learn unless they're actually in a place where they can engage as well. So thank you for sharing that. All right, and for Dr. Cleary, I was really excited to learn about your new position with the mayor's office. So I'd love to ask you a little bit more about when you're thinking about trauma-informed care initiatives, how are you thinking about partnering with organizations or institutions outside of the hospitals? Because obviously trauma-informed care for our patients doesn't end at discharge.
That's a great question. And so most of my work in the mayor's office is focused on essentially community level violence, which is peer violence, and thinking about the ways in which we often really are discharging folks back into the same environment in which they were injured, and recognizing that. I think the best example to kind of touch on and for us to all think about together would be actually how our ER identifies and treats and discharges folks who have experienced intimate partner violence. Even more so because unfortunately in Atlanta, it's really common that we'll get to a weekend night and the expectation is that there's not going to be a shelter bed available. And looking back over multiple years of kind of the clinical data, we're very frequently reaching that spot. And so I think what trauma-informed care helps us first do is just, again, like someone mentioned in the chat before, is validate folks' concerns. So when we are asking folks to identify experiences of trauma and then saying, we will help you go talk to a social worker, like knowing that we are actually potentially not going to meet all of the needs that someone brings to us. And that raises issues within our clinical team when we're thinking about burnout and our secondary trauma. It raises issues of re-traumatization when folks trust us. And it raises how systems need to work together to identify and respond to that. One of the things that we did with the kind of crush of COVID and the rise in intimate partner violence was we actually extended a CDU, like an observation protocol, for folks who experienced intimate partner violence, weren't able to identify a safe discharge plan. And what that does is it gives them an extra 24 to 48 hours to maybe reach their extended network through social media instant messaging, or be able to contact a shelter bed further out from the Metro Atlanta area. And that's been helpful because it does kind of allow folks additional contact with our social services and other institutions. It gives us an opportunity to kind of build better relationships with those organizations. So having specific contacts at our intimate partner violence shelters. And it gives us more data for us to engage our funders in the area and to really demonstrate the observed lack of services. So it really helps us kind of build coalitions to address it. So right now we're all working on thinking about what a family justice center could look like for the city of Atlanta, and we're using that clinical data to help folks understand what the unmet need is.
That's awesome. That's a really exciting intervention. Great. I'd like to open it up to the audience for some open Q&A time. I know there are varying levels of comfort with participating on Zoom, so we'll offer you a couple different ways to participate. If you feel so inclined, you can use the raise hand function and we can unmute you to help ask a question. You can also feel free to put any questions in the chat. I will be moderating the chat as well and can pass them along to panelists. You can also feel free to message me privately with your questions as well. And you'll find me under Taylor Brown on the chat function.
While we're waiting for those to come in, I just want to underline something that Nate said, which is that thinking about trauma-informed care, not just as patient facing, but also thinking about your entire team. So this is not the SAMHSA definition of trauma-informed care, but in my practice, what I've found is really valuable to think about how am I being trauma-informed to myself, towards my colleagues, on not just on the clinical team, but everyone around me, and to my patients. And that came out of sort of listening and paying attention, but also one night I had a nurse who came up to me after we had a difficult exchange with an agitated patient, where she felt unsafe. And she said, "What about my trauma?" And I think we really have to acknowledge that piece of it, or we will never have buy-in, and we won't be good at being the best for our patients either. So we as attendings really have to model that for our learners too. So I just encourage us to like think about whatever that means, but I really do think of it as kind of like a three-legged stool. And if you don't have all three components, like your cup isn't going to be full enough to be able to provide that trauma-informed care to your patients. So just wanted to underline one of the points that Nate said.
Yeah, I think there's a question in the chat too about nursing staff and waiting rooms and providing waiting room care, which that's certainly something we're doing at our own institution right now. I'd love to put another question to the panel. I know when Henry and I worked on the systematic review, most of the interventions were focused on clinicians, and then there's also a strong body of trauma-informed nursing literature. But to date, I hadn't seen anyone that actually looked beyond, all of our other colleagues that are helping in the emergency department. I don't know if any of you all have worked on any initiatives that call in all of our other colleagues.
Yeah, we did here at Hopkins. We had a grant for a program called the East Baltimore Community Trauma Response, which was a group that formed to do trauma trainings, both for like community organizations, folks in the community, as well as with different members of the sort of healthcare team. And so we did trainings with like our peer recovery coaches. We did trainings with our community health navigators, trainings with some of our nursing staff, trainings with the social work department, and lots of the kind of care management sort of folks as well, just to kind of express this sort of concept of trauma. And at the time, our city actually, as a whole, was embarking upon this big initiative to try to get all the sort of city sort of services trauma trained. And so I think building a sort of awareness of trauma was something that was pretty critical at the time. Unfortunately, COVID hit, and then that kind of limited a lot of the things that we were able to kind of do long term. And fortunately, I think the healthcare system kicked in and started establishing all these different sort of supports and other kind of systematic fixes to really kind of help us through navigate through COVID. But I think what I learned from the whole experience is that trauma is everywhere, that lots of people are hurting. One of the stories I remember, there was a person who worked in the culinary services whose son had been murdered, and he I guess was in our hospital for several days before he passed away, and she was given some time for bereavement, but then when she went back to her job, she had to her food delivery sort of route included that floor where her son was on, and every time she walked past that door, it was re-traumatizing, right? And so a simple fix was sort of bringing it up to her supervisor so that they can change the sort of route that she had to embark upon. But I think like those are just things that we don't think about as a system. They're relatively easy fixes, but they're things that can go a long way towards upholding people's humanity, making them feel valued, and really being the human-centered systems that we sort of aspire to be.
There's another question in the chat here about effective ways of teaching residents trauma-informed care. I don't know if Henry's still on as well, because I know you've done work in this area as well.
I can contribute a little bit of what we've been working on down at Emory with a great team. I see Dr. Gibson here. So one of the things that came out as we started thinking about how to like implement this was like it's really easy to sometimes identify things that aren't trauma informed, but actually putting together the positive version of it can be more challenging. And so we've done didactics and like highlighted some of these different sorts of topics, but then we've also instituted a champion sort of like monthly award to highlight examples of how people do carry that out. And that's across all the disciplines of residents and nursing staff in our trauma center. And I think that has helped kind of give it a little bit more positive examples.
I think the only thing that I would add, Taylor, from the previous work we've done, and I think this applies to the undergraduate medical and also graduate medical level, is also thinking about trauma-informed care systematically through SIM. And I think we use SIM for so many types of medical training. We do it for cardiac arrest, we do it for chest tubes, and I think it's also just as effective to practice it for trauma-informed care, as it can feel awkward, it can feel uncomfortable, and to try it out in a very safe environment where it's okay to fail, it's okay to make mistakes, and then also get really productive feedback. And I think, implying this principle is just the same as other medical principles, and, should be viewed no differently in that way.
I would agree with that. We've used simulation with in our sexual assault training, but we haven't really used it to yet generalize to other patient populations or where you don't know that there's a history of trauma. So I love just incorporated into the educational simulation with other types of patients where maybe they don't come in with the trauma, but it's the way they're acting or something that you do that they show a reaction that's unexpected. I love that idea.
Yeah, and this kind of gets at the two former questions, but I just want to give a shout out to one of my colleagues, Dr. Dana Im, who has designed an anti-racism trauma-informed care simulation that involves security. They're called basically our techs in the emergency department along with clinicians, and it's a simulation 2-hour thing, and their time is protected for that exercise, and it is a very powerful experience, and residents can certainly be included in that, and the debriefs afterwards, et cetera, are just really, really powerful. So another plug for SIM.
In our shop, we use a lot of humanities-based approaches to field some of these conversations, and so we've used narrative medicine and so reflections on a narrative piece. We've used art that might conjure themes related to trauma and have these sort of discussions, and use sort of the power of art as a third thing, which is kind of like a conversational mediator that helps to kind of modulate the tension between the depth of revelation versus what somebody actually wants to sort of speak about. And so I think it's really a powerful tool you can also add to your armamentarium in addition to simulation.
I apologize, my internet cut out with the lovely weather we're having in Boston for a few seconds. So if you've dropped a question in the chat, feel free to drop it again because they were all erased for me. But I think it's really exciting, a lot of the educational work that's going on in trauma-informed care. I put it in the chat, and I'll share at the end of the session that we will have a QR code that's going to link to a resource document, and a lot of the educational interventions that folks have mentioned will be linked on there, including several MedEd portal workshops that outline clinical skills and trauma-informed care. Those have mostly been developed at the undergraduate medical education level, but I think a lot of the basics are still applicable. And if the chat has gone quiet, Hana, you had brought up something earlier about trauma-informed self-care, and I was wondering if you could just talk a little bit more about that for folks that may have not considered that before.
I feel like this is a growing edge of practice for me. I probably have a lot to learn about that. I think it's something that I try to keep in mind and be aware. I think part of it is also in the same way that I'm kind of aware of my patient's hyperarousal states, but also to be aware of my breathing, my heart rate. And sometimes that means maybe I've come out of a room where I notice those changes in my body, and I just literally give myself a moment to be aware of that and to breathe before I go on to the next patient. And so there's the on shift things that I try to do in that vein. But I would love to hear from others as to how they engage in their own trauma-informed self-care. But I think for me, it's really started with like paying attention to my own body and the stress reactions I'm having, and really trying to like do what I can within the chaos to give myself a second to breathe and reset so I can be present for that next patient and be trauma-informed for them.
I've taught several co-residents about grounding techniques and grounding exercises, especially when I'm about to do like a crash line or a scary intubation and my heart rate is spiking. A lot of my co-residents have found that to be a really useful skill.
Thanks for sharing that, Nate, too. And thanks, Taylor.
I'd also say, someone I think in the chat brought up earlier, how do you teach residents trauma-informed care clinical skills? And someone said you lead by example. And I think this is probably another space where leading by example is possible. Every shop has different cultural norms. But I think even being selfish and taking 5 minutes, 10 minutes to eat something on shift, if you're doing that as an attending, it lets your residents know that that's also an okay thing to do.
And
one of the things one of the things I'd love to hear from other folks is we've done a lot with our residents, but is there anybody that has any interventions with the nurses in terms of trauma-informed care? Because I find that many of them may have assumptions or judgments on patients, and correcting those has been challenging. And so I'm wondering if anybody has any type of interventions they've tried.
We have recently done a kind of department-wide sort of intervention within our trauma center that included nursing, residents, kind of all the staff. And kind of going back to what you were talking about and kind of setting the example and thinking about how different folks would be responding to episodes of stress or potentially traumatic secondary experiences or personal experiences. We thought about, like Hannah, you were saying, grounding this in a quality state. So calling trauma-informed care the highest quality care, and then starting from the assumption that all of our team members would want to give the highest quality care. So we started with that kind of a framework, and then said, what are the like pain points that you have that make like prevent you from giving the highest quality care you feel like you could do? And we did focus groups with residents and nurses in our trauma center, just because we felt like folks who may have had like the least bit of agency in their workspace would be the best places to kind of focus us. And and we were able to come away with like kind of 4 general themes, and one of them was communication and resuscitations, one of them was pain control, another was de-escalation, and another one was against like staff care. So we started with the communication one, and we instituted a trauma-informed communication checklist. So with our trauma teams, we have an incredible trauma surgeon, Randy Smith, who led the trauma side of it. And then on the ER side, we did some training, and then we have a checklist that we go through that includes like having a single voice for the patient, having closed loop communication and kind of a summary at the end, and then an ability to do like a debrief, kind of opt out almost debrief. And we trialed that starting back in August. And we found that it really was well received and pretty well implemented kind of across the board with our level trauma patients. But I think starting with the perception that like identifying folks' pain points and assuming that they want to do the highest quality care has been really helpful for us.
Thank you.
There's some comments in the chat too about a hospital that actually has a TIC director that sits in the office of the CMO, which is amazing to hear at an institutional level. And then Dr. Stoklosa shared that some of the anti-racism interventions also included nursing colleagues in some of those educational interventions.
Ralph, we're all curious.
Yeah.
That's awesome.
Just appeared one day. What a blessing.
Yeah, they were pretty quiet about it. Nobody had heard anything until she showed up and introduced herself, and has run different educational sessions for the team. And given that so much of what we do in the emergency department needs to be trauma informed, and the patients we serve at our county hospital. She spends a lot of time with my nursing leadership and us. I'm not sure, like on an individual level, what she's done. A lot of her interventions have been, more educational and group based, but yeah, she's a very, very good resource to have. So
I'm curious if anyone on the panel has thought about trauma-informed care in some of our newer staffing, I don't know, just challenges in the emergency department, either with our travel nursing colleagues or just like the turnover. Other things I've thought about recently, someone had mentioned, waiting room care and how we're starting to provide care in really alternative and sometimes not ideal spaces. If any of your institutions or you yourselves have thought about trauma-informed care in some of these recent challenges.
Yeah, I mean, I think about it in terms of the transparency piece and the communication, right? So while we simultaneously try to change the system, which feels like an uphill battle, just being really candid and real with our patients, I think is important, and for all of us to be on the same page about how we communicate. But it's definitely not ideal, right? So I find myself apologizing a lot. And yeah, at the same time, we have to change the systems, right? So I think in terms of privacy as being a part of like trauma-informed care, and so far as it is, I think just being extra aware of that element and how we lose it. And there are in hallway and waiting room care. And are there ways that we can, within the broken structures, like create spaces to have that first initial private conversation? Or are there things that we can do in terms of flow that will allow people to have some moment of privacy with their clinician as a sort of Band-Aid? I saw Ralph had a hand up, but.
yeah, I was going to clarify my comment about the waiting room. So I wasn't thinking of it from the waiting room care perspective. Our issue has been mostly around our night shift staff, because we've had some cold weather here in South Central Texas, and we've seen an increased number of homeless people staying in the ED, coming in, blending in with the patients who are waiting, and then cause trouble, either harassing patients or making a scene when they're asked to leave, and those kind of things. And apparently a few of them have been much more aggressive than others. And it's a lot of the nurses are looking at it as a personal safety issue to them. And, we get it, or at least I get it. I've tried to talk to our nursing leadership about their concerns, but it's really a tough thing to solve, because, especially when they're throwing around terms like, well, what's it going to take? Are you waiting for somebody to be injured or killed? And, all these horrendous statements. But, we try to do our best to ask them to leave and escort them out. But then, of course, hospital administration is always worried about, if somebody has to be forced out or dragged out, what's that going to look like to all of the other people in the waiting room, and those kind of things. So it is interesting. And I don't have a good solution, but we're just trying to at least listen to them, let them voice their concerns, and try to figure out ways to do it. And, some of their own suggestions were also not very trauma informed. So they were asking to have police officers stationed in the ED and different things like that. So.
If it helps you at all, Ralph, you're not alone. We've got the exact same problem in our ED as well up at Boston Medical Center. And yeah, I think what we've done is tried to work with the city and see if there are alternate places that we can send people, work with the system. That has not worked so well thus far, but we're continuing to work on that. we have also put on extra overnight coverage where we have a physician that goes out into the waiting room to a pit room and screens people, and then they're escorted off. But yeah, it's a really tough problem, and I think yeah, I guess I can't overemphasize the importance of letting the nurses have a voice, listening to them, and continuing to work on it. It's a hard problem.
Yeah, and I think it's also important to recognize that many of our patients experiencing homelessness have undergone tremendous amounts of trauma, right? And so it's never black and white. And I think like that's the challenge with a lot of these systems is, you know, the EDs are set up to be the sort of safety net for this broken system, and it's supposed to be a catch-all that fixes everything. And it's impossible for us to do that. And I think we
100%.
we always have to think about like the harms, the trauma that we're causing on some folks to address the trauma on another. And so how we sort of figure out who to prioritize and when is you know, ultimately what defines us.
We are coming up at the end of the hour. And so I would like to start wrapping us up. I would also like to ask the panelists to share one final thought each. Trauma-informed care is primarily a strengths-based approach and framework. So I'd love to hear from each of our panelists tonight, something about trauma-informed care in emergency medicine that makes you excited or hopeful. We'll go in alphabetical order. So we'll start with Dr. Cleary.
I think trauma-informed care has brought a light to some of the ways in which we interact with each other in our clinical space. And I think as we've like made some advances and tried to implement some of these things, it brings out some really good things in our coworkers and in our patients. And so it's something that really, I think, helps me continue to love the job.
Yeah, I think this shift in framework from what's wrong with you to what happened to you really encourages us to be more curious about one another, and to really delve more into the humanity that each of us bring to the table. So I think that will be something that will help emergency medicine and help us as physicians in general to be better at what we do.
I found trauma-informed care to really help me feel less frustrated and more empowered with, I think, as you mentioned, the humanity and trying to have a deeper understanding of what's going on with my patients and with other people and how I can best help them at that specific time without feeling like I need to save them or that I'm going to solve anything. And yeah, that's what I like best about the model.
All of you, can I answer that's what gives me hope. The folks that tuned in, and also I just want to give a big round of applause to Taylor and Henry for putting this together. They're our future, and they're trainees themselves, and so I think that gives me hope, along with what everyone else said. So thank you.
All right. I have shared up on the screen our QR code for some additional trauma-informed care resources. I also dropped the link in the chat. I want to thank everyone for logging on tonight, for participating in the chat, and then I'd also like to extend a huge thank you to our SAEM staff for hosting, coordinating, marketing this event. I'll drop my email in the chat as well in case anyone has any comments or feedback on tonight's webinar. But thanks again, everyone. It was a great session.
Thank you, Taylor. Thank you, Henry. Everybody.
Yeah, of course. Thanks for logging on. All right. Thanks again, Erin. We're going to log off for the night.
Thanks so much, Taylor. You did great.